Hi, welcome to the session all about deep brain stimulation. My name is Dr. Celeste Seward. I'm the Patient Engagement Manager for the National Ataxia Foundation, and it's my privilege to welcome you to this PrepRARE session all about deep brain stimulation. Our speaker today is Dr. Ihtsham Haq, who's joined the University of Miami as Chief of Movement Disorders Division in September of 2020. His passion for the study of the brain began at Columbia University, at which he completed degrees in bioengineering and in philosophy. He obtained his medical degree at SUNY Downstate and his neurology residency training at Georgetown University. After his residency, he spent 3 years at the University of Florida's Movement Disorders and Neurorestoration program at the Norman Fixel Institute for Neurological Diseases, performing his movement disorders fellowship training. From there, he was recruited to Wake Forest School of Medicine in North Carolina. He spent the next 10 years there and reached the position of associate professor in the Department of Neurology and Neurosurgery. Since joining the University of Miami in 2020, Dr. Haq has overseen rapid growth of the Movement Disorders Division. The division now includes 6 fellowship-trained movement disorders faculty, 2 advanced care practitioners, 4 fellows, and practicing across 6 clinics in South Florida. And of note, I just want to mention that the University of Miami has recently received the designation as an Ataxia Center of Excellence from the National Ataxia Foundation. And with that, Dr. Haq, the floor is yours.
Thank you so much, Dr. Stewart. I do want to start with, besides disclosures, thanking Dr. Stewart and the National Ataxia Foundation both for allowing me to talk today. And also, as she mentioned, allowing us to join this great consortium of folks working to help people with ataxia. Disclosure. So, I do a couple of things. I've consulted for compensation for the deep brain stimulation companies, Medtronic, Boston Scientific, Abbott. I have research funding or salary support from the NINDS, mostly for Parkinson's related work, but also some AI stuff from Amazon and Slalom Consulting. Nothing that directly impacts what we're talking about today, with the prominent exception of the deep brain stimulation companies, of course. Okay, so I think it's always useful to sort of frame what it is I plan to talk about. So here we are. First, I'm going to talk about what ataxia looks like. I know you all know this perhaps better than anyone else, but it's worthwhile talking through the different ways ataxia can be defined, because we can also talk about ataxia as a circuit disorder, and describing it as one versus the other makes a big difference when trying to understand what DBS will work for and what it won't. I need to talk a little bit, of course, about what deep brain stimulation itself is, how it works, and what it's good for, of course. And so let's do that. So again, let's talk a little bit about what ataxia is to lay the ground for work for what's coming next. So first, there are lots of different ways to define ataxia, right? You can have a particular genetic ataxia, you can have that 3-letter code, you can be told you have SCA2, but in the end, one of the ways folks will define having an ataxia is seeing certain things. And the Ataxia Foundation website, here's a nice summary of many of the things people can see. So, of course, difficulty with coordination, problems with walking, eye movement abnormalities, and changes to speech as well. When we're talking about these different changes in movement, we can subdivide them into different definitions based on which particular component we're talking about. Whenever we're talking about a rhythmic, regular back and forth movement, we're talking about a tremor. That's worth mentioning because people often call things tremor, not incorrectly, that maybe strictly speaking aren't tremor in the scientific sense. It really needs to be what we call periodic and oscillatory. In other words, something you can almost set a metronome to. It just goes back and forth, as opposed to kind of the more irregular weaving back and forth someone might have in the way they walk when they're ataxic, when they're reaching for something when they're ataxic. So again, oscillatory, periodic, in other words, regular back and forth. The other stuff I was just mentioning is perhaps more dysmetria. Dysmetria is most obviously dysmetria when you miss a target, that's in the name, dysmetria, measuring wrong. But if you measure wrong in the process of a movement, you end up with that kind of back and forth movement that people may get with ataxia when they're trying to reach for something. And so both dysmetria and tremor can involve eye movements, speech, using your hands and the way you walk. We may have different names for it when they pop up in those situations, but in the end, we're still talking about mostly tremor and dysmetria. Of course, I'm mentioning these because these also map to different circuit disorders. Another way then to define ataxia is not just by how it looks, but what particular parts of the brain are affected. So this is a diagram of the brain, of course, taken in what's called a coronal section. So the person's eyes were looking out at you, and this is a section through about the latter third or so of your brain. What you're looking at here is a lot of diagrammy attempts to show circuits, the way different parts of the brain connect to each other. The parts of the brain that are relevant for ataxia, for tremor, for movement regulation in general are this switchboard part of the brain called the basal ganglia. Different things connect to each other and turn the other parts on or off in a connected way. So what I just said, I hope, is essentially this: that movement is regulated by communication between these sort of different key brain centers. And dysregulation of that can lead to tremor and dysmetria. But the way in which they're dysregulated is different. So in tremor, what you get is superimposed hypersynchrony. Of course, I'm not leaving those words at that, but I'm going to come back to those terms. I want to establish them. Hypersynchrony. Synchrony is when things speak, work, act at the same time. Hypersynchrony, of course, is when they do it too much. Superimposed means it's on top of. All right, so superimposed hypersynchrony. If these things, these parts of the brain are constantly talking to each other, what superimposed hypersynchrony means is there's this additional signal where these parts of the brain just kind of fire all together, all at once. And that's actually not what you want your brain to do. You want your brain to have this kind of diffuse, very different pattern. Because if you think about it, if you think about the way we communicate information in general, the brain included, communication only happens when there's a variation in signal. What do I mean? Well, for example, just take the text on this page. Imagine if this page were entirely black, if every pixel, like every cell, was activated, or entirely white, every cell was off. It would convey no information at all. The same thing happens with hypersynchrony. What you can think of tremor being then here, this superimposed hypersynchrony, is as a signal goes through a particular area, everything turns black at once. So it's all in activation that turns off, and all in activation turns off, and that creates a tremor, this periodic hypersynchrony. Dysmetria is more complicated. Dysmetria is just different parts of the brain perhaps not talking as well to each other as they should. So the speed may be slightly off, there may be something wrong with the communication, but it's not as simple as cells just firing too much or too little. All right. I'm going to come back to that, so try to keep that in mind, because now I'm going to talk about deep brain stimulation. And to provide a spoiler now, what I want to describe is how DBS is really good at getting rid of tremor, because you can interrupt that abnormal signal, but unfortunately not as good at interrupting dysmetria. So more complex issues with motor planning and targeting are not going to be as DBS responsive. So with that spoiler in mind, let me talk a little bit about DBS. So what's deep brain stimulation? I think many of you will know, but for those who don't, it's implanting electrodes deep into the brain, helps the deep part of deep brain stimulation to regulate malfunctioning brain circuitry. So the idea is the same as a pacemaker for the heart. In fact, it looks a lot like a pacemaker for those of you who've seen one. Here's the generator sitting in a person's chest, except the wires don't go over or down to the heart. They go up underneath your skin, up to an electrode, and the electrode is implanted again directly into those regulatory portions of your brain that I was describing in the slide before. Again, tremor is a superimposed hypersynchrony, and you can interrupt that relatively easily. So DBS is really, really, really good at getting rid of tremor, but for more complex issues in motor planning and targeting, unfortunately, just overriding the signal is insufficient to treat the symptom entirely. People are looking at cool approaches, but we'll talk exactly about that. So let's say you've got a bad tremor and you want it gone. Is DBS worthwhile? Well, it's a matter of assessing the risks versus the benefits, and that's mostly what I'm going to talk about for the rest. What's DBS good at? Well, hopefully I've made this point sufficiently, but I'll continue to make it anyway. At interrupting hypersynchrony, so anytime something in the brain is happening because cells are firing together when they shouldn't be, DBS is great at that, but not so good at getting things to talk to each other better, which makes sense. It's much easier, I think, to wipe out a signal or to replace a signal than to create sort of the complexity and dance of the interconnectedness of the basal ganglia. So what are the issues? Well, there's always the potential for side effect, low risk, but there's always a possibility of bleeding and infection with any surgery. That's true for deep brain stimulation too, anywhere that you need to make a cut. The disadvantage here is one of the things you're doing is implanting something into the brain. And a bleed in the brain or an infection in the brain, however minor, is still perhaps a much more serious matter than a bleed or an infection just under the skin. So let me talk more about what DBS is good for. So I'm going to talk about a couple of different conditions because now I'm sort of branching out into the history of DBS to sort of come back and explain what works and doesn't work for ataxia. There's this concept of essential tremor, which I think many of folks will have heard of. Essential tremor is a wastebasket category. I use that term to say that it's a place where we put stuff that doesn't fit very well in other places. It's not spectacularly organized. Anything that has a regular back and forth movement during movement can validly be classified as essential tremor. So there are a lot of people with mild ataxias where the ataxia perhaps is not as apparent. The difficulty with gait, the difficulty with coordination is not as apparent as the tremor, and that gets classified as essential tremor. Dr. Stewart was mentioning to me that you all had a talk about Fragile X associated tremor syndrome, and that absolutely is an example of a situation, a condition in which many patients will have mostly a tremor, potentially as their main condition, even though they have a primary ataxia. So that's the oldest indication for essential tremor all the way back in 1997. Parkinson's disease is where a lot of DBS gets directed, approved in 2002. Like I said, perhaps the most common indication, about 100,000 people implanted worldwide. Dystonia, which also can pop up with ataxias, by the way, although I haven't discussed it so far. Dystonia is that issue that develops when your brain tells two muscles to contract at the same time when they shouldn't. So for example, your bicep pulls your arm up and your tricep extends it out, but if your bicep and tricep pull at the same time, then your arm ends up kind of locked. Or similarly, for muscles that perhaps are not as commonly thought of, if say your sternocleidomastoid and your splenius contract at the same time, your head may get stuck over on one side. So different kinds of dystonia pop up. Since it is, again, a movement regulation issue, actually it pops up in ataxia, although I think it may be an underreported symptom, excuse me. That was approved in 2003. An HDE means a humanitarian device exemption, so it wasn't subject to the same degree of rigor as the other ones were, but it's approved. And similarly for obsessive compulsive disorder, because believe it or not, a lot of the psychiatric conditions also come from aberrant hypersynchrony, although in different parts of the brain. And that was approved in 2009. Epilepsy is yet another situation in which cells are jumping up and down together when they shouldn't be. So again, aberrant hypersynchrony, so no shock there. It works for certain kinds of epilepsy. It was approved in 2018. That's the most recent approval for DBS. So how do you tell if a patient is okay to have DBS? Well, the first thing is to see a movement disorder neurologist. If you're going to be considering a surgery as complex as this potentially is, it's really important to know that you could benefit from it and to hear from someone who might tell you that it's not for you. So we're usually the first step in evaluating people. We confirm the diagnosis, as I mentioned, and make sure that you need the surgery, because after all, if medication can do the same thing as surgery can, I mean, I love doing the surgeries. I've probably done 500 or 600 of them at least, but I'd rather treat a person with medication if I can. And then also to make sure the things that a person wants to get better are the things that DBS could get better. If you come in saying my hand shakes and I need that to be improved, great, DBS can do that. If you come in saying that, you know, when I walk, I kind of stagger back and forth, unfortunately, DBS has a very low likelihood of affecting that. And that's something you want to know before you start thinking about going through everything that DBS involves. Of course, once that's confirmed that DBS might be a good idea for you, there's a neurosurgeon too. As neurologists, we're there in the OR, and I'll show that in a few slides. But we're not the ones who are actually in your brain. That's their job. So they'll discuss whether it's to be done awake or asleep, the details of exactly how the electrodes can be guided into place, and so on. All the important things that are surgical. But also, there are other people in the team who are no less important for you mentioned third. We need to make sure that people are set up to be cared for in general. I mean, if you're seeking out a surgical intervention like this, often your condition is in a situation where there's a lot of caregiver burden as well. And it's important to make sure that your team at home is ready for this surgery and for your condition as well. Neuropsychology is critical to make sure that we're not potentially going to cause harm as well. In other words, these conditions, ataxia, Parkinson's disease, dystonia, sometimes involve circuits besides just the motor circuits, often involve circuits besides just the motor circuits. And as circuits get strained, the circuits tend to pick up double duty, sometimes triple duty. And so some of the same motor circuits that will be affecting, if you've got cognitive changes, they might be doing some cognitive work too. And that means when we adjust them, we could unintentionally alter your thinking also. Not a common side effect, and certainly not as long as you screen for it. That's why it's critical that you screen for it. And physical therapy and therapy broadly is crucial both before and after surgery to do the best that you can do. So I mentioned the neuropsychologist, the neuropsychological evaluation. That you would think from the word psychology, you might think that involves things like looking at anxiety, depression. It does, but the majority of it is a cognitive evaluation. So if you remember way back when you had any kind of evaluation for primary school, where you might have had to name as many words as you could or match colored blocks to one pattern or another, that sort of thing. It feels very IQ testy because the idea is to look at the different kinds of brain function or cognitive domains that you could have involved and make sure everything is functioning well. And if it's not, it actually doesn't mean you can't have the surgery, but it does mean we need to have a discussion about what the potential complications might be. And then, of course, it's not sufficient for you to meet these people in isolation. This is why it's important to have a good team working on DBS, because you really want to know that everyone's gotten together and discussed the case and looked at everything that needs to be looked at. All right, so that's what is involved in getting to the table. Let's talk about the actual DBS procedure itself. So the first thing you'll do is the neurosurgeon and the neurologist will plan the procedure together, get an MRI of your brain, take a look at where the target potential is, measure that, use a computer to program exactly how the electrode will go down, and then that's that. In the operating room, as we put the electrode down, we actually listen to the cells of your brain in a process called microelectrode recording, another thing I'll show in a future slide. And we can actually hear the aberrant hypersynchrony, and that can help tell us we're in the right location. One, two, we can test the location. Once the electrode is down, you can actually turn it on, and if it's not doing what it should do, then we can move it until it does. So how long the first step takes varies depending on how many times you need to test a location. Usually the microelectrode recording time is about 45 minutes or so. Of course, it takes time to get you onto the table, frame on your head and frame off your head. So even though the surgery itself is perhaps 45 minutes or so, or the part I consider the surgery, the whole process is a couple of hours. And you can put either one lead in at a time or both, or two. But each lead you put in will control the opposite side of your body. So to control tremor in two hands requires two electrodes to be implanted. All right, step two is putting in the pacemaker. The electrode is just an electrode. There's no control there. There's no autonomy. It's just a very sophisticated wire. So that wire has to connect to the pacemaker, to the generator. That's the stage two. That goes in what we call a pocket, i.e. a little space that's made under your skin where it'll be implanted. It's literally the same as a pacemaker procedure. And then it's connected to the wire that connects to the electrode that's actually in your brain. When everything is healed is when you actually start programming. So typically programming starts a couple of weeks after this second stage. So here's a look at the components. There's the electrode itself that's implanted in the brain. There's a little cap that holds it in place. By the way, if I haven't made this sufficiently clear, all of this is under your skin. It's not as though you could see any of this from above, except that the cap makes a slight bump or so, about the size of, say, 3/4 stacked on top of each other. The lead continues over to about typically behind your ear or so, and it's connected to the extension. This then goes down to the battery in your chest. We can program this, we do program this externally. The programmers come in different varieties. Some are just apps on your iPhone, believe it or not. Some are standalone devices, but all of them allow both the physician and the patient various degrees of freedom in programming the devices and directing that stimulation. To talk a little bit about targets, so like I said, you're trying to pace different parts of the brain, trying to change the way different parts of the brain work, trying to wipe out hypersynchrony in different parts of the brain. The 3 points in that switchboard that have been best studied are a part called the thalamus, and that's mostly what we're probably talking about for ataxia and tremor. This is historically the most potent site for improving tremor. There's another area that was originally described, perhaps more Parkinson's disease, the subthalamic nucleus, right under that same area that helps control tremor and that also directly controls tremor. This has been explored more recently for tremor control and ataxia and tremors in general, and the globus pallidus, which is a target that's typically more used for Parkinson's-like symptoms, also controls tremor, but perhaps not as easily or robustly. So for ataxia, for tremor syndromes, we're mostly talking about the thalamus and the STN. Here's a look at what is entailed in getting the electrode localized. So it's a stereotactic frame. In other words, something that shows us where things are in space. Either there's a frame that's attached under local anesthesia, or there's a mini frame that's a smaller version that floats more free. There are advantages and disadvantages to each, but both are used and both are, well, that would get into useful for particular indications. We can get to that if folks are interested in the questions. Otherwise, I'm going to let that go because that would be a longer topic. Similarly, I'm only going to briefly talk about awake versus asleep surgery. There are advantages and disadvantages to both. You can do microelectrode recording in both situations. We can hear your brain whether you're awake or asleep, and so we can have a good idea of whether that hypersynchronous signal is there or not. But if you're awake, we can test the electrode in a way we can't if you're asleep. If you're asleep, you don't have a tremor. And so we can't see if we made the tremor go away if you don't have a tremor at that time. Most people tolerate the awake procedure quite well, and we can always convert an awake to an asleep. In other words, if you're having trouble, the anesthesiologist is right there to take care of what's needed. Whereas if you're asleep, we're kind of stuck. Different centers do it differently. Most of the places I have been have preferred awake surgery. Okay. Here, the planning software has changed so much over the years. This is an older version as I look at it, but the basic idea is the same. You've got pictures of the brain at different angles, and you look at how the electrode would travel, and that's how you do your planning. This is an example of how things have advanced. If you look at this previous one, you can tell there's just kind of a brain, and you might imagine the neurosurgeon has to use their eye to see where the electrode tip is going. Now we have varieties of automated atlases, which show us where structures are. It used to be that you had to manually sort of overlay these. Now the computer automatically detects where the borders are and does it for you. This is an area of the surgery that continues to advance and advance rapidly, especially with the introduction of AI. But all of this is to me, interesting to you, I hope, but perhaps less so, way of saying that the technology continues to advance in ways that better and better tells us that we are, or just as importantly, are not in the right place to get an effect. So here's an example, here's an example of what we might see while doing the microelectrode recording. You see this signal. These are actually cells firing, these little peaks over here. And you can imagine that they are happening at sort of different frequencies. The lines are happening at different intervals between these, and these are different depths and different parts of the brain at different depths. And that's how we tell where we are, whether we are where we're supposed to be or not, by seeing if the pattern corresponds to what we think we should see. Hopefully sound is working for you. So this is Dr. Luca, whose slides I liberally stole for much of this with his permission. I'm going to press play again, and you'll hopefully hear him talking to the patient, but you'll also hear the staticky noise in the background. And as it progresses, I want you to notice that static, that is what it sounds like, is going to happen sort of in time with the movement of this patient's hand. I think it gets more apparent as it goes on, like chop, 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 chop. And there's those hypersynchronous bursts happening as well. So that's what we do in the OR. We put the electrodes down. As we put them down, like I said, we take a listen to whether or not that's happening in the right location. We're in the right location. What I'll show you is another thing we also do. So behind the location where you get the aberrant hypersynchrony for tremor is a location where you gather sensation. And so to also localize electrode to know that perhaps part of it is further back than it needs to be, we also do this. We look for tactile cells. So what Dr. Luca is going to do here is rub the patient's face. And you should hear that when he rubs it, you hear that kind of staticky noise, but not really otherwise. This can be a little bit harder to tell, but this recording hopefully makes it easier than some of what I see in the wild, as it were. There, they're kind of slow, static. So a lot more subtle. There we go. So those are the kinds of things we do to make sure that we're in the right spot, besides, of course, actually testing it. Let me talk a little bit about how DBS has worked for different conditions. I can skip Parkinson's disease, I think. The place I want to really focus is cerebellothalamic tremor. So cerebellothalamic, connection to the cerebellum and the thalamus, which is most of what we're talking about for ET and for ataxia. And we use this when the tremor isn't responding to medication, and the response rate is quite good. Studies have repeatedly showed about 2/3 of people improve. The numbers are better than that now, actually. I need to put in a new reference, closer to 85 to 90%. And it's the thalamus that's the typical target. And this is the kind of thing we look at. So we look at people's spirals before and after, and you can see that what happened here was the patient had to trace within the spiral. As you can see, it was very difficult for them to do this regular back and forth movement. And then once we turned, and here's handwriting, an attempt at a signature, once we turned it on, it really straightens out quite a bit. So let's talk a little bit about ataxia finally. So mostly what we have for ataxia are case reports. So folks have not done large series. Here's a typical one from about 2 years back. And what this shows is for this case series of 5 people, if you read into this, exactly what I think I said, the tremor gets better, a lot better. People feel better, quite a bit better. But when they actually measure the ataxia isn't a whole lot different, the SARA score before and after DBS. So I'm going to talk about some things we're doing to try to find a better target for ataxia. But if ataxia isn't an on-off phenomena, and it may not be, there may not be a point in the brain at which you can simply just turn ataxia on or off, at least we'll still be able to control tremor and other, again, hypersynchrony issues. So,
can we stimulate here? Just stimulate?
by the way, again, you're hearing the hypersynchrony in the background, you might look recording.
When we get down to 1.5 or -2.5.
All right, and so then with stimulation.
So I don't planning for all these things. So I'm going to start it again. Don't worry. 0.5. It's normal to get that. Actually, that's a good sign. Okay. Yes. And you're gonna feel it for 5 seconds. Good. That's expected.
Looks like I can't skip ahead. Sorry. No.
Good. That's expected.
We'll have to wait for the first minute.
Planning for all these things. So I'm going to start it again. Don't worry. 0.5. It's normal to get that. Actually, that's a good sign. Okay. Yes. And you're gonna get.
You might be wondering what he's talking about. The patient felt some numbness, some tingling when it was turned on the first time.
So it's when it goes away. Okay, so we just increased the stimulation 0.5. All good. The tremor improved, I would say 50%. Okay, good. So 2.7, right there. Okay. Do you feel any tingling?
So again, the idea is, as hopefully I've sufficiently hammered, that when it's this regular and rhythmic movement, you can make that better. And that is a manifestation of an awful lot of ataxias. But if we're talking about kind of the difficulty in movement, coordination problems, that's less responsive because it's just a more complicated issue. Like I said, I'm going to talk about ways in which we're hoping to improve that in the future. I see, it seems like a lot of questions that are popping up in the chat are around that question, naturally. So, one more video.
So right now the DBS is off.
And this is again essential tremor, but some of you may recognize that this pops up in people that you know, or perhaps you yourself, with ataxia as well.
We need to wait about 10 seconds. What is
All right, just turn it on.
It's tingling, but it's calmed down.
And the tingling is for the same reason as
your nose?
that slide before, where we were
Fingers.
touching the patient's face and you're getting
Cover
that
your
staticky
eyes.
noise. The back part of the electrode, the lower part of the electrode often will be closer to areas of control
And then
sensation.
back like
If you
this.
stimulate those, you'll get the tingling. It usually passes as long as we're programming
Now it's
correctly.
back on.
There you go. So of course, I mean, that's the reason to get DBS, but if this were a discussion, and I hopefully get into the questions, more about like how to go about getting DBS and who's a good candidate and who isn't, I would stress a little bit more that there is a percentage of people who have bleeds and infection, around 1 to 5%, depending on the case series. So it's best established, I think, in Parkinson's disease, despite ET being the initial indication. I think the PD literature dwarfs the ET literature at this point. Repeatedly, it seems to be both safe and effective in that condition. Let's talk about who a bad candidate for deep brain stimulation would be. I've touched on some of these, so it's worth, I think, bringing it up this way. If you have a lot of cognitive impairment, again, why? Like I said, that's a complex network within your brain controlling movement. And a lot of those circuits have the capacity to do more, to take on more duties, to train. And so if the circuits that normally would help with cognition are having a hard time for one reason or another, the movement circuits will have taken up some of that control. You can think of it that way. And so then now when we're influencing them, we're not potentially influencing just movement, but also cognition as well. And that's typically only with significant cognitive impairment, because like I said, your motor circuits have to be helping out your cognitive, have a need to help out your cognitive circuits they wouldn't normally have. There's always some double duty, but this would be taking it to another level. And so that's what neuropsychological testing is supposed to do, is to identify that risk. Untreated depression, anxiety, psychiatric illness of any type, same reason. Again, if those circuits are impaired, then other circuits are going to be behaving differently also. And so that's something that needs to be well controlled prior to going to DBS. Or of course, if for one reason or another, you can't go through the surgical procedure. I mean, no harm, no foul if you're claustrophobic or for whatever reason, it is that this particular process doesn't work for you. There are alternatives. The other surgical procedures we're not going to talk about today, but things like focused ultrasound are important to know about. There are advantages and disadvantages. The big advantage is it's less of a surgery. Disadvantage is that you're burning a hole in the brain, perfectly effective way to interrupt a circuit, but you can't adjust it over time. And I mentioned this before too, unrealistic, I need to change that word because I don't mean to put the onus on the patient. Sometimes the thing you want to be better just isn't something you can make better with DBS, and you deserve to know that. And again, and hopefully folks aren't tired of the repetition, but it's such an important point to me to say that more complex things like like the dysmetric component of ataxia, difficulty with coordination, difficulty with, well, coordination popping up in different ways, coordinating eye movements, coordinating speech, coordinating a smooth movement. Those are just not likely to improve with deep brain stimulation as we know how to do it currently. And of course, you know, a surgery is a surgery. So if you are an uncontrolled diabetic or you have found congestive heart failure, it's going to be less safe for you to be on any operating room table, including a deep brain stimulation surgery. Potential complications, briefly, folks can have some confusion afterwards. This tracks with what I was mentioning about cognitive difficulty. This typically pops up in people who already have some degree of mild cognitive impairment. Things like urinary retention pop up like they do for any surgery. Hemorrhage. So you can have a bleed in your brain, about 1 to 2% risk, and that can be nothing in terms of symptoms, or it can be a bleeding stroke. Serious issues happen perhaps 1 out of 100 times. 1 out of 100, though, as I always tell patients who are asking about this, is not 0. So I've operated on about, like I said, 500 or 600 people. Yeah, I can remember 5 or 6 bleeds that have caused people problems afterwards. Infection, this is usually less of an issue because it usually occurs at the neurostimulator site. So it's a wider incision, so it's natural skin bacteria can get in there. And when that happens, the generator has to come out and antibiotics, and you can put it back in. Typically, infections do not result in permanent removal of the device. Most people who get infections want the device back in because it tends to work well. And we do typically put it back in after sort of a 4 to 6 month cool-off period. The devices have gotten really good. This really doesn't happen much anymore, but it used to be 10, 15 years ago. Leads could break, not that they would snap loose in your head, but that like a contact would no longer be as well connected as it was before. Or the lead could migrate, like it would slowly descend slightly downwards in the brain relative to where it was supposed to be. We really don't see these anymore, but it's a conceivable thing, and it did used to happen. Stimulation related. Okay, so I mentioned that people have numbness and tingling during the test stimulation, and that we understand that because when we do the surgery, we double check the location by seeing if we can activate some of those cells as we're there. So usually that's happening because the electrode just isn't placed quite correctly, frankly. And that usually can be minimized by adjusting the stimulation. It used to be that all you could do was turn an electrode on or off, basically. So it's like a flashlight. It would just go not like a flashlight, like a light bulb. It would just go everywhere. They are now differently shaped and set up, so they are more like flashlights. So they can point more in one direction. So you can point the stimulation away from areas that cause these problems now, to an extent. But stimulation-related side effects still happen, at least transiently. Interestingly, you can create ataxia with DBS difficulty if you're stimulating the wrong regions, because you'll be dysregulating circuits that should be regulated, that should not be getting this additional signal. Okay. This is simply to sort of describe how the stimulation looks or has looked in the past. Stimulation has mostly been the situation of on and off and on and off and on and off. So there's a brief pulse and it drops and a pulse and it drops. And it's about as close to a square wave as the device can deliver. In other words, it pulses and sort of stays on for a brief interval. The pulse width is really brief. So 90 microseconds is sort of a typical one. So these are millisecond duration pulses. And the idea here is you're actually overpacing the cell. Your cells fire themselves all the time. So what this does is it fires just slightly faster than the cell does. So it doesn't give the cell a chance to relax. And to some extent, it turns it off. There are more complicated effects too, but that's, I think, one of the first ones to mention. I think we can skip past these side effects. Okay, so I mentioned that when you put the electrode in, used to be you would turn it on and it would just stimulate all around like a light bulb. There are 4 contacts typically per electrode. Some of the newer ones, actually, depends on the electrode, but they each have a number of divisions, and you can stimulate from each one of them. Again, non-directional DBS, what we used to do is you put it in and it just stimulates. You could do things to change the shape of the field. So you could stimulate more on one than the other. You could alternate between them so that one would pulse and then the other one would turn on. And on average, you would get this kind of sort of differential activation. And you could also activate more or less at one or the other, and so shape it continuously. These were things that honestly kind of saved us when our electrodes weren't perfectly placed. If your electrodes are perfectly placed, as is still the case, it just kind of works. But when you're hitting areas you don't want to hit, this lets you get away from them a bit. All right, directional DBS is cool. So here you might see that there's a little cut or a slit or gap in between these 2 components. So this is the way a fractionated electrode, a directional electrode, would look to you. But if you rotated it around, you would see 2 more of these cuts. And so you have each of these electrodes split into thirds. And so there you go. So in this case, you can put it down and you can activate all of them like before. Or you can activate just one. Like I said, a bit more like a floodlight than just a regular light bulb, pointing more at one direction. So you can imagine if this was an area you didn't want to stimulate, you'd be avoiding it, as opposed to omnidirectional stim. you can do a couple of really interesting things in terms of how you're stimulating as well. It also happens to save energy also. And so it saves battery life, although these days we mostly use rechargeables, so that's not as much of an issue as it used to be. But it also allows for more steady and targeted stimulation. So it's always good not to be hitting things that you don't mean to hit. We'll skip past that, because I do want to leave about 15 minutes for questions. I guess the key thing here is we have much more capacity now to precisely change the electrical field to hit exactly the areas we want to hit and no more. But there's more than that too. Okay. Sorry, looks like I have some doubles of slides there, but I didn't realize I did. Okay. So there are some interesting things, since I want to talk about advances also in terms of programming. So you saw, if you recall before, that picture of the brain with those outlines on different parts of the brain. So we can also do what are called connectomics. So we can look now not just the structures themselves, but how they connect. Because those telephone wires that run between each of these switchboards are not arranged in exactly the same way in every person. They're close. But they're different enough that trying to target those specifically could make a difference. And people are starting to look at that. Related to that, but not entirely, that is image-guided programming. So what we used to do is we used to turn one electrode on at a time and see which one was best. You know, we would turn the electrode on over the course of a couple of minutes. We would try different settings on it and go, okay, that's how that one does. Let's go to number 2, and then you do number 3 and number 4. That very quickly became less feasible once we had these divided electrodes, because every time you create more possibilities, you create more possibilities. So at this point, with 3 components to each of those middle electrodes and all the other settings we have, we've gone from perhaps 50,000 potential settings to a couple of million, if not more. So automated ways to narrow those choices down are important to have. Image-guided programming basically just means you can look at the person's brain itself, or a mock-up of their brain, and use that to guide you. This is the same thing we do in the operating room, but you know, the resources that are in an operating room are not always available outside of it, and were not for a time, and now they are. So we have the patient's own images now, and this is true for all the devices that we use. Each company does this, and we can program based on where things look like they should be. So even more, so that's just structure, that's where stuff is. And I've talked about looking at what's connected, but again, that's structure, that's just looking at what it is. We can look at how it acts. So local field potentials, what this means is we can actually measure that frequency firing. So going back to that oscilloscope stuff that we saw before, when I was talking about hypersynchrony, you saw the video of the test stimulation. You can analyze that and look at where there are more frequency, where the cells are more typically firing, in other words. So let's say what you're showing here is that lots of cells are firing, say, 10 times a second, but not many are firing 30 times a second. And then what's the point of that? You can do that at different locations. And hey, when you have cells that are mostly firing at 10 times a second, actually that usually means that's where the hypersynchrony is living. That tells you potentially that without looking at the structure, just like doing microelectrode recording in the operating room, outside the operating room, you can look and say, this is how this brain is actually acting this second. So that's what's happening here. You're looking at these different frequencies, and when one frequency band or another is higher, it means that one or another problem might be popping up. And so these local field potentials can be analyzed and collected, and you can actually look at these frequency breakdowns, and you can localize exactly where a tremor might be happening. So what's happening here is you're trying to isolate what's called a beta band. This is for Parkinson's, not for tremor, but the idea holds. And the beta band, this particular kind of overactive brain signal where lots of cells are firing together about 20 at a frequency about 23 times a second. When you've got a lot of that, you have a lot of stiffness and slowness. You can say, aha, this is the place where I should try to interrupt the signal, this particular location on the electrode. And lo and behold, it works. Interrupting hypersynchrony is what we're trying to do after all. So being able to measure that and then interrupt it seems very logical, but has only been something we began to be able to do within the last couple of years. In other words, our brain electrodes now can read as well as write, if you want to think of it that way. And so this is really exciting, I think, because this is letting us actually, like I said, program to a patient's own brainwaves. It's best established with the beta peak and PD, so I'm going to talk about that, even though a theta peak, for what it's worth, would be more relevant for tremor, most likely. Oh, here we go, sorry. Beta alpha peaks. And so you record it, and then you can program again at this. What's happening here. So if you're looking at this particular location versus this location, versus say this location, you might see that there's more of a peak here than there is if you check at a different point, and then you know that this is the place where you need to interrupt that abnormal signal. And here's the thing I'm going to talk about next, is that this potential creates a potential for what's called closed loop DBS. So what is that all about? Because closed loop DBS perhaps is the most exciting thing I want to talk about. We'll talk about that and then we'll be done. So closed loop DBS, the idea here is you read the brain waves and in real time you respond to them. So you may have noticed that the kind of way I was describing programming thus far was kind of a set and forget strategy. So you turn on, and those are your settings until you adjust them. What closed loop DBS means is that the electrode then, since it can read a person's brainwaves, would have the potential to respond to those brainwaves with a particular targeted kind of stimulation. Right now, relatively less sophisticated in that it's only looking at location only. That was something we dreamed of a decade ago. But what it's doing is saying that this part of the electrode is where the stimulation should happen, so this is where I'll stimulate. And it could change over time depending on which part of your brain was doing a thing on one point or another. But the cool thing is, of course, you're not limited, once you're allowing the computer to do this in an automatic way, with just a particular program. You could let the computer figure out what the best pattern is for stimulation. That's where things really are right now, is adaptive stimulation. So adaptive closed loop stimulation, which is what we're hoping for, which we're getting to, I think, relatively soon, is truly to have DBS that's specific to an individual. You plant the device senses what kind of stimulation ought to be delivered and where it ought to be delivered, and then just delivers it. So this is coming soon because it's partially here. And like I said, I think this is what we're most excited about. The ability to truly adjust without having to manually adjust. And I think that's enough to tell you, because I see that I've only left 10 minutes for questions. I see a lot of them piling up in the chat. So I'll say in conclusion, ataxia, remember, includes both dysmetria, weaving back and forth, mistargeting, and tremor, this regular movement. Tremor responds to DBS beautifully, dysmetria not so much yet. DBS is super effective for tremor, but you want to weigh the pros and cons. These advances I've been talking about in measuring electric patterns in your brain and how your brain looks can show us where to program. We're learning newer ways every year with exactly how to target a particular location beyond just let's aim for this spot that's always worked. We'll have more flexibility in programming. Truly personalized programming is coming, particularly adaptive DBS, where it reads your brain and then fires in response. And we're going to make this a personalized affair, I think, in short order. That's everything. So thank you. And I appreciate your sitting through all that.
Thank you so much, Dr. Huck. We're going to dive right into questions. As a reminder to please put your questions in the Q&A window so we don't miss any. We're going to get through as many as we can. So just to clarify, we've had a number of people ask questions clarifying what kinds of symptoms, again, can be treated by DBS. You've talked a lot about tremor. People are interested in the balance symptoms also caused by ataxia, because not everyone with tremor has ataxia, not everyone with ataxia has tremor. Could you go over this again for us in terms of what benefit it could offer folks who are experiencing balance-related symptoms?
I'd be happy to, because in the end, that's what matters, right? Does it have the potential to make you better? And I have to say that unfortunately, again, if your main issue is not tremor, if it truly is the dysmetric, discoordinated portion of ataxia, no. At this point, it will not improve your balance.
Very good to know. But it seems like if people are having tremor as part of their ataxia presentation, that this can be an effective way to treat those symptoms.
100%, and there is a lot of research going on into gait, so I think this talk will look quite different next year, certainly 2 years after that.
That's very good to know. And then a clarification question. We had an attendee who wasn't sure if some of the speech symptoms they have are the dysmetria or if that's related to
Yeah,
tremor. Could you comment on that?
it's tough to tell, honestly. So if you'll forgive the imitation, if your voice goes back and forth like that, if it's a regular oscillation, it's a tremor. And yeah, that could respond. If it's not, if it's tight and more dystonic, maybe. And if it's something else entirely, if it's the kind of thing that you truly often get classically with ataxia, then no, it's not going to respond. So it depends, remains the answer.
Very good to know. Then we have someone who asked, does it matter what triggered the tremors in the first place? And
Yeah,
does that impact the
great question.
success of DBS?
That is a great question. For tremor, not so much, actually, except insofar as it changes how the tremor's manifestations, then yes. In other words, as long as it truly is a tremor, as long as it's a regular, rhythmic, oscillatory signal, those all respond really, really well. But say if you have a tremor from multiple sclerosis or from ataxia, sometimes there is this dysmetric or discoordinated component to it, and it's the same thing again. It just does not respond as well. The more regular and rhythmic it is, the better it responds.
Thank you for clarifying that. We have someone who asked, you mentioned that some of these devices are rechargeable. How does that work?
Oh, that's a great question too. Like most other devices, of course, since the battery's in your chest, you can't just like snap it out and put it in a charging dock, but they do something pretty close to that, where you have a separate thing which you put in a charging dock, and then you charge that will then charge the device over the course of half an hour or so. In other words, what'll happen is you'll have like a hockey puck looking thing that you charge from a socket, and then you just keep it over your chest, usually in kind of a little hammock thing for like half an hour or so every couple of days.
And then we have a follow-up question to something you mentioned a bit earlier. You talked about coming soon. So research that's going into DBS about how it could be used for more wider application. Someone's just clarifying, were you speaking about adaptive DBS or were you mentioning, referring to something else?
There's a lot. So I was referring to research in general. So I guess a couple of points on what to look for in trying to parse through the research. First, be aware that anything that helps, say, quote unquote, essential tremor is going to be most immediately translatable to folks with ataxia, as those loops perhaps are most involved in both. But the PD literature is important too, especially when it touches on dystonia. So all the things that we're talking about with PD, with dystonia, et cetera, ET, in terms of being able to measure signal and reprogram signal is going to be repurposed for ataxia. But next.
And then we have someone who received DBS surgery for essential tremor this year. Has been very successful in the management of their tremors, but now they are having continual sneezing and hiccups. They're wondering if that is a common side effect or if that could be something related to their ataxia.
So it's not a common side effect at all.
Mhm.
It's conceivable it could be related to the stimulation, but it would be unusual. The easiest way to tell is, I mean, you turn the device off briefly, and if the sneezing goes away and it comes back, you turn the device back on. I mean, it's related. It's weird, it's reportable, but then it's related. But if it's stimulation dependent, then that's the easy way to tell, off then on. Is it related to your ataxia? Also not typically, but
Mm.
insofar as ataxias can involve brainstem circuitry as well, and that area does control hiccups, vomiting center, other swallowing related issues, possibly.
Good to know. We have someone who's asking about earlier you mentioned that if medication is treating their symptoms quite well, the people will prefer to stay with medication rather than recommend DBS. Is there a time frame where that should be revisited, where frequently medication may stop working? How often should people be discussing this with their clinician as an option?
That's a great question too. And I think for anyone who has even a chronic condition, checking in with your physician once every 6 months, once every year will keep you abreast of sort of what the latest is. Medications should be abandoned as the primary approach when they're not working anymore. So either they're
Mm,
not tolerated or you've reached doses at which further increases aren't expected to provide
mm.
additional benefit.
And then we have a few questions about the surgery itself. So to start off, what does a typical DBS surgery cost, and how do most people pay for it?
Isn't it weird that your academic doctors often are not well set up to answer that question? I mean,
Mm,
unfortunately, there are entire banks of folks who manage the insurance side of things who can give you the specifics, but no, of course, I know in sort of a ballpark way. I know that you absolutely could not, would not, I would not want you to try to cover this out of pocket. I mean, the device alone, raw cost is 50K or so. No one pays,
mm,
I hope, 50K for this, but that's what it costs, like just the component. That's without the OR time and everything that goes into it. There's a copay involved, like most surgeries. One of the reasons we don't know is not just, defensive ignorance, but also insurance is complicated. So
mm,
depending on what kind of procedures are covered, what county you're in, what insurance you have, I mean, it ranges widely. Okay, the nutshell, it's typically very well covered because it actually saves the insurance company's money to
mm.
have a person implanted with DBS because it really does improve function over the lifespan for the majority of people. So it tends to be a supportable cost with insurance, but you kind of have to find out beforehand. Yeah.
Oh, thanks for explaining that to us. And then we have a few people asking, is this kind of surgery available in many places, or do you have to go to specialist centers?
I would strongly recommend going to a specialist center. I wouldn't dream of not going to a specialist center with ataxia as a primary indication. There's too much. There's too much possibility of other things being involved, of cognitive changes, et cetera. I think a non-academic center is perfectly reasonably set up to do things like Parkinson's disease and especially essential tremor. I think that a non-academic center would be very well set up to do the procedure itself. I like to think, although I imagine there's some bias there, that seeing a movement disorder specialist, at least to clarify and confirm the diagnosis, and there's nothing else going on, that you're a good candidate, would be important to do first. The general will be the more implantations, like any surgical procedure a given center does, the better off you'll be getting it done there. That typically will be an academic center, yeah.
And then one final question. Someone was wondering if you could share a little bit about your Ataxia Center.
Oh, wow. Yeah. So, I mean, we're brand new, right? We've been doing Ataxia for a while, but I think this is an opportunity for us to do it in a more coordinated way. So we're really excited to get started. So I'm going to talk both about what we've done and, what we plan on doing. As far as what we've done, I mean, from a genetic standpoint, I'm proud to say, has really been a powerhouse, especially over the last couple of years. The FMR gene, a couple of other important genes that really are responsible for a lot of people's ataxia were characterized here. We're also members of the Undiagnosed Disease Network at the
Mhm.
NIH. So there's a capacity even outside the Ataxia Foundation to get your ataxia diagnosed. But our goal is to do what we've done for Parkinson's disease and Wilson's disease and the Parkinsonism, which is to bring comprehensive care to the person. So making sure you can, in one go, see physical therapy, speech therapy, genetic counseling, your physician. So you don't have to try to make 6 different appointments over the course of 6 months.
Mm. It's nice to have a one-stop shop where you have all that expertise in one place.
Critical.
And with that, we are at time. Thank you so much, Dr. Huck, for speaking with us today. We really appreciate both your time and your expertise.
It was sincerely a pleasure. Thanks for asking me.
And thanks to all of you for attending this webinar and spending the last hour or so with us. I hope you found out something helpful today. And wherever you are in the world, good morning, good afternoon, good evening. Have a wonderful day ahead. Take care, everyone.